Hello, I'm Dr. Kiran, orthopedic surgeon with subspecialties in spine surgeries and rheumatology. Cervicobrachial neuralgia or the neck pain with shoulder pain is the discussion topic. Let's hear a question, Mrs. Banashri Badraji from Visakhapatnam, Andhra Pradesh, India.
Hello, Dr. Kiran. How are you? I have a question for you. I'm suffering from neck pain and also shoulder pain. Are these two related?
Thank you, Banashri ma. Now just imagine how painful it would be. You come home at night and you put on the switch and there is no light. So you immediately go into an investigative mode. Whether what happened? Did you pay the bill? The cables are at fault. So we ponder so much about a failed light. Then should we not analyze shoulder pain with neck pain even more? The medical students are highly advised to pause the slide. There will be so much of matter which will take at least 1 week for each slide to be understood by you. When we connect the dots, when we understand the problem, what happens? There is light. Patients also must go early to the clinician. We are all here to help you. So the electric circuit is an apt example. The cause could be anywhere in the circuit. It can be in the switch, it can be in the wiring, means the nerves, energy source, brain or the cervical spine. And again, see, afferent. You receive a signal, we process it in the brain and we send it out. If my hand is getting, burnt by a candle light or something, I just remove it. Pinprick, I remove it. If I want to catch something, I'll go and catch. I'll give a shake hand when I want to. Because my brain is working, my nerves are working. It is telling me, please shake hands. So this is the efferent. This is a motor response. When I see visual response, I see somebody, I smile. So many things are going on in the brain. So all these things you cannot compartmentalize all of these things. When a patient comes into the chamber, understand what is happening. He or she may come with he may come like this, he may come like this, so he may come like this. So the way he comes itself tells you the diagnosis. Now this is a very important slide. Why? Neck pain or any pain, chronic pain is established by research that it causes permanent damage in some parts of the brain. Even chronic neck and shoulder pain were found by measurement of various modalities, regional homogeneity, the take-up of hemoglobin, oxygenation, all these things they studied and the scans showed certain areas of the brain to be affected. And in chronic pain syndromes, they were permanently found to be affected in the functional and structural aspects also. But in CNSP, chronic neck and shoulder pain, the correlation is still not established. It's under research. So these are some articles. Hope you pause, look at this article. Chronic neck pain, a resting state of functional MRI, fMRI, functional MRI study. In this patient group, what they found significantly increased reho in bilateral middle frontal gyrus. What is it? Pause. Medical students, pause. Just check where is the middle frontal gyrus. Here it is decreased in left insula, superior frontal gyrus, middle cingulate gyrus, supplemental motor area, right postcentral gyrus, superior parietal lobe. What are all these things? You have to go back to neuroanatomy, then you will understand. This preliminary study also suggests one more thing, that these brain regions may be suitable targets for chronic pain management and provide a foundation for other research to extend treatment strategies for CNSP, chronic neck and shoulder pain patients. Now, cause of pain could be sometimes from the brain. See, our nervous system, brain, can have many problems. Of them, tumors are also there. Let's go along the age groups. There can be a small child with shoulder and neck pain. Patient is not able to see sunlight, sir. Or some other headaches, intracranial pressure is increased. Night he is not sleeping at all. Without a good examination, if you just brush it aside, patient may end up losing life. Ependymoma, when it is at the neck region, it can cause shoulder pain. It's of rare occurrence, but still, we have the duty of examining properly. It must be taken seriously. Now, cervical origin of pain. What is the cervical origin of pain? For example, this is the vertebrae. Inside you have the spinal cord. There can be a disc coming out. It is in the center, only neck pain. If it is in it is compressing one exiting spinal nerve, that hand will give pain. If both are being compressed by a broad, diffuse protrusion or a big bulge, neck and both the limbs can be painful and paresthesias and many other things go wrong because they will give rise to compression of the nerves. Nerves supply the muscles. Nerves do not work properly. Muscles do not work properly. When muscles do not work properly, the joints will not work properly. So a person coming with shoulder abduction difficulty or any other stiffness or any other disuse or whatever it is, wasting or whatever it is, I agree that shoulder pain can occur isolated, just due to a local cause. But according to research, 23 to 25% of shoulder pains are related to the neck. So how can we neglect that? Cervical origin of pain like entrapments, disc herniations, spinal stenosis, neurovertebral foramen stenosis, hypertrophy of the uncinate process. So medical students, please stop. Refer to each. What is this? Disc herniation, what is it? Spinal stenosis. You have to know. Don't move on. It's not a entertainment video. It's an educative video. Outside the cervical spine, it's in the house. Now I go out, I open my door, go out. The nerve goes out through the neurovertebral foramen. This is the neurovertebral foramen. Once the nerve comes out, many things can happen. Injuries can happen. Inside the spinal cord also, injuries can happen. When it comes out, it forms into many roots, trunks, divisions, cords, RTDC. Okay. So outside the cervical spine, entrapment. It can get, see, two muscles are there. They're getting tight. So the nerve which goes off like this is getting strangulated. It's like pulling my necktie. My voice will change. If I release it, it will be alright. That is the thing that happens to the nerves. Now shoulder pain, muscle impingement like I told you, and also cervical ribs. So there can be extra ribs in the C7 region causing extra length for the plexus to pass through. Then there will be neuritis, neuralgia, brachial plexus injuries. Okay, somebody falling down, or even during birth, you can have obstetric palsy. Abnormal presentation. There is a distraction between the neck and the shoulder during birth. So it leads to a brachial plexus injury. The baby may be crying and there is no movement of the limb. This can be in different degrees. Just a little temporary neuropraxia or totally axonomesis, right? You have tingling, sensation, wasting, not able to abduct or adduct, or the thumb becomes weak. All these things, grip becomes weak. They must be taken very seriously. I have to give you one example. I had one who had a very chronic drop of the index finger. When I saw this, I examined, I told him, I think you also have a cervical lesion. Then I did an MRI, X-ray, everything. There was a big C5, C6, C6, C7. Nerve roots were getting very severely compressed. I told him, sir, you have to get it decompressed and also then give physiotherapy. If still this does not improve, then you have to do a tendon repair or a tendon transplant or tightening. So he became lax with time. What happened? He went to a hand surgeon. Hand surgeon did a tendon repair. He tightened the tendon, Z-plasty. Did he recover? No. How will he recover till this is recovered? So finally, at a later stage, after 6 months, he went for a cervical surgery and this is under physiotherapy now. Meaning, we should not become like the 4 or 5 blind folded people trying to see. I see an elephant's leg and say it's a pillar. Somebody sees a tail and says it's a rope. Somebody sees the ears and say it's a sieve. Somebody sees the trunk and says it's a rubber hose or something. When the blindfolds are removed, they say it's an elephant. Please try to connect the dots. Then the elephant is seen. When a patient comes saying, sir, I have pain here, sir, pain here, sir. C2, this is C2, this is C3, this is C4, this is C5, C5, thumb is C6. Patient comes telling you, he will show you. So please, these are all pearls or the advices. Pay attention to what the patient is stating because he is or she is the sufferer, not you and me. The diagnosis is right there in what the patient is saying. They point towards the area of radiation and if disregarded, it's a loss to both the patient and the doctor. It is sad that practically happens. Somebody comes with a paper, a prescription or some medical report treated by other doctors. They look at it and then the same line of treatment diagnosis goes. Respects to whoever saw before. But believe in yourself first. So when the paper comes, I just put it aside and say, I'll look into it later. Please, let me examine. I come to a conclusion. It is not professional ego, please. It is dependent on your own self. You are seldom wrong. Why did the patient come leaving that doctor? Because he was not cured. Or other problems, transport problems, many things. Once we understand the dermatomes, which are the best navigators, like we have in cars and other things. See, like I told you. C2, between the ears C3, back of the shoulder C4, lower part of the shoulder and neck is C5, along the shoulders is C6, down C7. So much is there. Each Each is showing thoracic, even the lower leg also. So please do not miss this slide. Stop here, medical students. Go into it. Even young practitioners. This is the best advice I can give you. So once the nerves have come out of the neck, now we have got plexus. These brachial plexus, RTDC, like I told you. Doesn't it look similar to the internal wiring which the electrician does? So this is how the brachial plexus and peripheral nerves all exist in our body. Sensory nerves take the message, and the motor, the response is given by the motor nerves. So it all takes place in the spinal cord under the control of the brain. So many things can happen along the lines. Like for example, if you have a dorsal root ganglion diseases, autoimmune, viral or anything, the sensory system doesn't work. If you have a ventral motor neuron disease, then the motor system doesn't work. Patient becomes wheelchair bound. Okay, they may be normal. See, we are all timed machines, human beings, or any animal is a timed machine. Genetics plays a role. Sometimes suddenly after certain time, health fails. What is the significance of thoracic inlet? What is thoracic inlet? What you see here, so many structures are there. And what happens here? We have muscles, arteries, nerves, veins, lymphatics and others. It can cause skeletal and bony abnormalities like the cervical rib, soft tissue abnormalities, poor posture and weak muscular support. They all can cause lot of symptoms. Mostly are neurological, vascular, electrophysiological changes. So management is tailored according to the symptoms. Physical therapy is the main treatment. Surgical decompression is reserved for patients with symptoms of vascular type of thoracic inlet syndrome. So you please again pause. This is a big slide. It will take at least 4 or 5 days for you to understand, medical students, right? Thoracic outlet. I talked about the inlet syndrome. Now thoracic outlet syndrome, something that goes on around the cervical rib. So what are the boundaries? What can happen here must also be clearly read by you. This can also cause neck pain and shoulder pain. Now this is a very important slide. One orthopedic surgeon was treating a shoulder. See, it is not a professional comment, anti-comment. No. I'm just telling you mistakes. Mistakes. I may commit mistakes too. Why not? We are all human beings. My emphasis is, if you want to be successful, you have to work hard and try to always connect the dots. Sometimes in our memory, the dots disappear. We all age. We are busy. Our clinical acumen comes down. That is why CMEs, regular publications, research is important. This doctor entered pain, stiffness of the right shoulder of 8 months, no history of trauma, injection dipomedrol given to the shoulder, notes about presence or absence of neck pain missing. There were no notes, but in reality, patient was stating that neck pain, dizziness. Why does dizziness come? See, you see, I just put a pen refill through. We have got cervical foramen, neck vertebrae. Through each of these, the arteries go up to the brain and then they'll become like a tree and supply the various parts of the brain. If certain movements in certain age, after certain time, the hole, and this is the artery that's going, hole becomes tight. So when you do something like this, it becomes ischemic. Vertebral artery will be stenosed or compressed or just a spasm. They can be transient or permanent, leading to giddiness. So these all must be seen. This patient had also said radiating pain to the shoulders. His arms, elbows, tingling of the hands. X-ray of the C-spine was not done. This is my exact point. Don't miss it, my friends. It's better to have writing notes, a little bit of notes. So in today's scenario, we are too busy, we have to type, we have to see the patient. Sometimes these things happen. The X-ray showed, reduction in the cervical lordosis, multiple disc space narrowing, severe compromise on the cervical roots on the MRI. This is a very important slide. There are 4 rotator cuff muscles. All these 4, supraspinatus supplied by C4, C5, C6. Infraspinatus, C5, C6. Subscapularis, C5, C6, C7. Teres minor, doubtful, C4, C5, C6. So these nerve roots are coming from the neck. So how can we neglect them? We have to connect the dots and do a good diagnosis. Thank you so much, my friends. I hope it benefits somebody about neck pain and shoulder pain.